Okay, so I left off on chapter 16. Let's see if we can get it to move. Okay, so we left off chapter 16 in class talking about so finished behavioral treatment. So we spoke about seizures and talked about the treatment for seizures, anticonvulsant therapy, but then we also talked about how some of these treatments can have side effects. Actually, we talked about side effects within the context of antipsychotics. So anticonvulsant medications can be used, and also surgical removal of the abnormal tissue. I actually had a friend who had tissue removed due to epilepsy, and what he ended up, while the seizures stopped, he ended up losing peripheral vision. So he did not have his periphery the way we do. So he had to actually turn his head in order to see the periphery. So while surgical removal can help, it can also cause other issues. So moving on from there, there are also neurodegenerative disorders that seem to have some sort of things that we know lead to the neurodegeneration, but we don't know why that neurodegeneration happens, what sets it off that makes someone basically have this problem. Dementia as a term is a much broader term. So this, when they say somebody is suffering from dementia, it could be intellectual impairment or social or occupational impairment as a result of some sort of degeneration. Okay, it's acquired, so it's not something that you just have, right? You're not like born with dementia. It's something that comes about, and there are non-degenerative dementias that sort of, it could be due to injury, it could be due to something like that. But then we also have degenerative dementias, which have some level of perhaps genetic cause, right? So Alzheimer's is actually a good example of a degenerative condition that might be linked genetically, whereas non-degenerative conditions, such as neurosyphilis, is actually a really good example. Post-traumatic dementia, that's somebody suffering some sort of TBI. Any sort of like Korsakov's, which is like that vitamin B12 deficiency as a result of chronic alcohol or drug use, that is considered non-degenerative. But then we also have degenerative disorders, Huntington's, Wilson's, Parkinson's, that have a clear genetic sort of link, but we don't quite know what sets it off. Okay. If you'll notice, actually, before I move on, MS is located in the non-degenerative side. This is because MS does not have as strong of a genetic link. So just because somebody in the family has MS does not mean that anyone else really will develop it. But I mean, it seems to be more of a effect possibly of environment and stress, but not quite sure on that either. So Alzheimer's disease is sort of what we're going to focus on. Most of dementia cases are Alzheimer's cases, and we don't really know the cause. We know that people can be genetically predisposed. Again, this doesn't mean that they will develop it. It's just a predisposition. Toxins in the environment could be a cause. it could be an autoimmune response, so very similar to MS is an autoimmune response. Guillain-Barré, if anyone's heard of that, also sort of like a degenerative, not degenerative in the dementia way, but it's sort of neurons that are not communicating with each other. It leads to some sort of paralysis, basically. So autoimmune response, it could be some virus that people have picked up, and that coupled with the genetic predisposition sets off a slow sort of response over time. And it could also be the result of reduced blood flow. There are things happening in the brain anatomically that might be causing this. So amyloid plaques have been commonly associated with Alzheimer's disease. And they're located mainly in the cerebral cortex, so not subcortical regions. And they've also been found in other dementia patients that don't have Alzheimer's. So it could be that the amyloid plaques are actually not Alzheimer's specific, but more so a sign of cognitive decline. And then there are also neurofibrillary tangles, and these are essentially sort of like helix-shaped bits found within the cerebral cortex and the hippocampus, so also going subcortical. But this has also been found in individuals with Down syndrome and Parkinson's and other types of dementia, which again makes them not Alzheimer's specific. There's a great deal of cortical degeneration that happens in the brain of individuals with Alzheimer's. So we see a lot of degeneration in the limbic cortex. If you guys remember, we talked about the entorhinal cortex within the context of memory. And this is probably why memory is one of the first things to go. This is one of the earliest and clearest signs of Alzheimer's disease. So essentially there's sort of broad neural degeneration. Limbic cortex, remember these are motivation systems, and then you have inferior temporal cortex and posterior parietal cortex, so lots of different kinds of functions. Actually, I read an article recently that that loss of smell is one of the first things that happens in individuals with Alzheimer's. So individuals who, as they age, it's sort of thought to have been normal that sense of smell goes down, but now they're finding links with the development of Alzheimer's as well, which is kind of an interesting fact there. And then the areas of the brain that are not really affected as much are sensory and motor regions. So the individual is still able to move, they still are able to feel things, but their processing will be off because of the other damage throughout their system. So look at the effects on the brain. You can clearly see some of this degeneration in the parietal region. You can clearly see a little bit happening here in the temporal lobe. And then, of course, we can't see the inside, but it seems to have been some degeneration in there as well. So one reason why the brain seems to be dying, the gray matter seems to be dying, might be because the dendrite, the sort of arborization or those branching out of the dendrites is decreasing. And that in and of itself could also be related to loss of neurotransmitters. So if that communication isn't happening, for whatever reason, there aren't things binding to receptor, there aren't chemicals binding to receptors, there isn't electricity sort of being transmitted between neurons, then those cells will die because they're not useful. So acetylcholine, noradrenaline, dopamine, serotonin, NMDA, and AMPA glutamate receptors. Remember, glutamate are excitatory receptors. All of these start declining, they start going down, and part of that could have been because the dendritic arborization. So check out how distinct and how very clear this dendritic arborization decreases. You see in that first picture here, normal adult pattern, and as you move through the stages of Alzheimer's, all of a sudden you have a neuron that really only is a cell body and an axon, and no dendritic arborizations at all. So let's move to actually psychiatric illnesses. So we have a number of disorders that we hear a lot about but actually aren't very common, and then we have disorders that we don't hear as much about in the literature or in the media, but are actually very, very common and affect a great number of people. So schizophrenia is really something that everyone's heard of, but really it only affects about 1% of the population, whereas something like social phobia, 13% of the population. This is more, we think about disorders that may seem a little weird, but many times we think about it as the cost to life and society. So an individual who's suffering from a psychological or psychiatric condition cannot work, they cannot care for themselves, they might incur more costs, healthcare costs, costs for treatment, the fact that they are missing days of work, things like that. So think about, if you have 13% of the population with social phobia, what are the effects of social phobia? Well, very often these individuals avoid going places that they would have to be socially evaluated in. So work is a major area that might be affected. So it's actually very damaging to have a disorder like that versus, generalized anxiety, still costly, but tends not to have as avoidance. It's a lot of just worry and tension associated with it. And then look at the rates of specific phobia, 11% of the population. These are fears of very basic things like heights or water, all the way down to getting injections, which is far more common. I bet, I kind of wish we were in class, like I could ask her to raise a hands, but just think about what sorts of things you might be afraid of and whether it's sort of an irrational fear. It's much more common than we let on to, than we let on. So we're going to start first with the psychotic disorders. Schizophrenia is diagnosed using the DSM based on these 6 criteria. So the individual must have delusions. So that's essentially a belief, not a perception, but a belief that something is, but that it actually is not. So these are things like someone's watching me, I have been appointed king of the world, the CIA is after me, things like that. So these are all delusions. Then we have hallucinations, which are perceptions that are distorted. In fact, the most common kind of hallucination is not a visual hallucination, they're auditory hallucinations. So people will talk about, someone told me this, or they always say that they hate me, or I'm stupid. They say that I'm stupid. Well, oftentimes it's a auditory hallucination. Then we'll see disorganized speech, sentences that just don't make sense. The words make sense, but the sentences themselves do not. Disorganized behavior or agitation. I'll show you guys great examples of all of these. Catatonic behavior, these are sort of body posturing or and such. You don't see it as commonly, but it's there. And then negative symptoms like lack of emotion in the face when they're talking or in their voice. sort of symptoms of depression, like not being really interested or wanting to do anything, and not reacting sort of normally to situations. Schizophrenia has a couple types. There's type 1 schizophrenia, which is mainly positive symptoms. These are things that are too much. So hallucinations, delusions, agitated movements, these are things that add on to whatever a person normally is. And it usually comes on quick and has a better prognosis and responds better generally to treatment, okay, so to the neuroleptic or antipsychotic drugs, like Haldol or Risperdal and things like that. Unfortunately, however, then you have type 2, which is predominantly negative symptoms. These are things that are missing. So no emotions, no interest, cognitive things declining. And this is actually more chronic. So whereas this comes on quick and sudden, this one is sort of a long-term building process, and it lasts for a very long time, poor prognosis, does not respond as well to medication, and it can actually be identified at the neural level. So if you do MRIs, you'll see you will see enlarged ventricles, as well as atrophy or sort of decreasing of gray matter in the frontal cortex. So here's a video depicting, hopefully this will work, depicting 4 different patients with schizophrenia. And I'll forward it if it starts getting too long.
There's going to be a hearing tomorrow to see whether or not there's any legal basis why you have to stay here.
I'm not crazy.
If it was up to you, would you like to leave the hospital tomorrow?
I'd like to leave the hospital tomorrow because I've got things I got to do.
Okay, well,
It's the first of the month and there's a lot of rent to be paid and all that.
Okay, what brought you into the hospital?
I turned myself in on a 5150 because I felt like killing myself.
Okay, so you came here voluntarily.
So I could stop from killing myself.
And what was going on that you felt like killing yourself?
It was 3 o'clock in the morning. I couldn't sleep. All the same thoughts kept racing through my mind over and over and over again. I just wanted them to stop. Period. Then I thought, well, if I kill myself, I'll stop thinking. And I thought, well, that isn't too good of an idea either because you've got friends and people around you who love you. So I stopped that thought. And I said, well, who am I going to call? And I called up Ghostbusters. No, that came out wrong. It's a joke. I didn't call Ghostbusters. I called a crisis intervention center and talked to them on the phone. They said there was nothing they could do for me for one night. So I wound up here by ambulance. Paid an ambulance to take me.
Okay.
Because the crisis intervention couldn't do anything for me.
Have you...
All right, so guys, just to point out, notice how he made a joke, but what's the normal reaction in a joke? We usually laugh or some way of giving away that it's a joke, but there was no change in affect, right?
Ever made any suicide attempts?
Oh yeah, I have. A couple of them when I was 19.
Okay. Are you usually able to ask for help when you start feeling like that?
No, I was never able to ask for help before.
Okay, so this is a new thing.
This is
You're
a new
coming
thing
into
for
the
me.
hospital.
Yeah,
Okay.
the way I came in here is unlike any other way I've ever come into a hospital. Asking people to please help me so I do not kill myself.
That's all the questions I have for you right now.
Can I go back in now? Yeah, I'm getting very uncomfortable out here. I think somebody might be trying to shoot me. Someone might be trying to kill me.
I got TV tooth, they call it. TV tooth is when they're surprised and they put little needles into your scalp. And they listened to me for years, if you know it or not.
Really?
I didn't know it. They have this really fantastic, expensive equipment they touched me with. And they said to me, hey.
So if you guys look, the diagnosis here they've given him is a rule out of schizoaffective disorder. You guys will learn more about this in Abnormal if you haven't taken it. And mood disorder with psychotic features. So know that you can have psychotic features, not have schizophrenia. In the case of this gentleman, TV tooth is a common symptom. It's a common delusion. And it's coupled sometimes with hallucinations as well. And it's the idea that someone is reading everything they do in their mind. So it's like they're recording your brain, basically, or watching everything that you do through this device.
We can check your head, for if your bump shows up bruises and the electricity is a little different across the scalp of your scalp, we'll guarantee you Social Security from that injury or on its own. It's considered like cerebral palsy, but it would be muscular dystrophy kind of thing. And so I said, no, think about it. And the next day he comes back and says, did you think about it? Get me right, and all that. I said, oh, okay, I'll look at it. Okay, let's go. And then they put the needle in. The last one they put in, they went like this. So when they did it, I had a thought when they pulled them out, they pulled them out perfect, but they left a little teeny little barb in every one of the places they put me. And they recorded it. And one person who wanted it didn't. Someone else sold it to someone else. I don't know who, but they're able to give a response back because of how thick the dental is in my teeth. How thick the dental is. And with the needles, they're easy to focus a heavier field of pickup reception because of all the fillings I got. And so
Who's listening?
I think it's people like at Stanford and technicians, wealthy technicians and people that do stuff like NASA or any of that kind of stuff. Ames Institute. I came right up to them and tried to sell them that last little one. But for the amount of money they didn't have, I should have just gave it to them.
All right, so if you guys note with the last guy, he did have some disorganized speech also. So he was saying stuff that really didn't follow a logical thought pattern. All right, so watch this woman.
The point where I don't want to live anymore because the mental process of the mind takes over. When I think I'm doing good for a while, something mental takes over and it scares me. Years ago, I didn't do that. Years ago, I didn't have to worry about that one thing. I was one less paranoid. One less crazy. I was one less crazy.
All right, so here's another good example of disorganized speech. What does that mean, one less crazy? It's not actually a thing that we say. It's sort of like a stereotyped phrase that she's come up with. Usually people will say something like, I was more or less crazy, but it almost seems like she's saying that she was less crazy, not actually crazy.
Well, years ago, I didn't have this new mental problem. I don't know what it is. But it's pretty scary. That's why I called the police. Nobody else was doing it. For those people at 7-Eleven, they're always on the phone talking about me. Always. Especially in the summertime, nice weather. They're always talking about me, calling hospitals, Barnes, St. John's. There's a lot of doctors at not 7-Eleven, Quick Trip. You know what Quick Trip is? There's always a lot of doctors and nurses going there making appointments like kill her or do something to her.
Do you notice changes in your attention, with your illness?
Huh?
Do you notice changes in attention with your illness?
I'm retarded.
But do you notice having problems focusing attention or keeping your attention on things?
Yeah.
Tell me about that.
I don't know. What was that again?
When's the last time you felt good?
I don't remember. It's killing me.
All right, so now you see, they call it asociality, but you're starting to see agitation as well as some of these negative symptoms of sort of like depression, maybe withdrawal from others.
It's keeping me from having a boyfriend, keeping me from driving. It's killing me. Like in China or somewhere.
All right, so also disorganized speech. Boyfriend has nothing to do with that situation, and also China has nothing to do with what she was talking about.
If somebody's been suffering years ago, they should take an OD and die, because psychologically they may not want to take the OD, but to get out of their misery, they might. They fight it every night. And every day he's always fighting with me. Michael's always fighting with me. Drop dead, geek, retarded bitch. Oh, that stuff doesn't mean shit to me anymore. I'm so used to it. I do have a brain problem.
All right, so now you see a huge change in affect, and it's important to note that Michael in this situation is not real. It's not a real person, but she hears somebody tell her, that she's stupid and dumb and whatever.
But I don't have a brain tumor.
You sit down. How are you doing? I'm doing so hot. I think and feel as though people have called me here to electrocute me, judge me, put me in jail, or kill me, electrocute me because of some of the sins I've been in. Is this a new feeling for you? The main thing is don't get excited, but the thing is it's not a new feeling, no. I'm scared of people.
Must be very frightening for you, though. Feels like you're about to get killed.
I'm so scared I can tell you that picture's got a headache.
Can you tell me more about that? The picture has a headache?
You want to know?
Yes, I do.
Okay, when a sperm and an egg go together to make a baby, only one sperm goes up in the egg. And when they touch, there's two contact points that touch before the other two. And then it's carried up into the egg. And when they fuse, it's like nuclear fusion, except it's human fusion. There's a mass loss of the proton. One heat abstraction goes up in the electron, spins around, comes back down into the proton to form the mind, and the mind can be reduced to one atom.
At this point, what would you like us to do for you?
I'd like you to get me off of cigarettes, get me dried out, cleaned up, so I can go home and get a job in a bakery and go to medical school.
All right. So this, what you're seeing here also, that man sitting there, that was a catatonic behavior. But really interesting stuff. All right. So going back to our PowerPoint. So if you saw it, this is actually very different from what sometimes we associate with schizophrenia. We think someone who needs to be strapped down and controlled, and it might be that these individuals do get out of control, but more often than not, they appear pretty typical. But it's not until you talk to them and you sort of know the context of their thoughts that you realize what's really going on. And you also saw 4 very different presentations in terms of the kinds of things that they were worrying about, the beliefs that they had, the symptoms that they showed, sort of their body language and behavior. The woman had far more affect than that first man or the last gentleman did. Okay, so genetics plays a pretty large role in the development of schizophrenia. So if you are an individual as an identical twin, their twin will have about 70% chance of developing the disorder. but there is no single thing that accounts for it in terms of mutations. There are some genes that that have been related. Mainly diagnosed in, I want to say, the 20s range, young adulthood, but some literature suggests that this is actually something that starts developing very, very early on in an individual's life. Environmental factors that affect brain development can be involved in this. So when we think about things like severe trauma as a child or neglect as a child, these can all lead to development of these symptoms. Things that happen in the brain, I mentioned the large ventricles, thinning cortex in the medial, temporal, and frontal regions. There are also the fibers and neurons in the temporal and frontal lobes don't look right. And I'll show you guys an example of what that looks like. And then dendritic fields in the prefrontal regions, hippocampus, and entorhinal cortex are also atypical or abnormal. So here is the organization of the pyramidal neurons here in a typical normally functioning individual. And then here you see this disorganized, sort of all over the place organization of these pyramidal neurons. So some of that disorganized speech and disorganized thought patterns that you see could really be the result of this very simple disorganization here. Right? They're organized in this way because they need to talk to each other, they need to follow a line. Whereas in this case, you have a lot more sort of randomness that could happen. We've talked in depth about the dopamine hypothesis of schizophrenia, but we know that it is also too simple of a solution because otherwise, antipsychotics would cure everyone, and it doesn't. You don't need to know all of these, but maybe just know a few. Just the number of things that can possibly go wrong in the brain as a result of schizophrenia. So glutamate receptors are atypically functioning. Dopamine receptors are atypically functioning. There's more of them. There is less GABA in the prefrontal cortex. Remember, GABA is inhibitory, so that would lead to some of that dysregulation also that we see. And then mood disorders, moving on. We have depression, mania, and bipolar disorder. We've talked about these a little bit within the context of medication. And we know that neurotransmitters like serotonin and dopamine and norepinephrine have been associated with depression, but again, very simple sort of link, and we don't even know if it's a direct link or not. There's been literature that depression is a result of sort of decreased levels of this brain-derived neurotrophic factor we talked about in development. Remember, this is important for the production of neurons and keeping healthy the neurons that we have. And so stress can decrease the numbers of brain-derived neurotrophic factor, and antidepressants can actually increase the production of them. There's also the HPA axis, hypothalamic pituitary adrenal circuit, that's involved in stress and the release of cortisol as a result of chronic stress. And this has been associated with depression in adulthood, more specifically. And it's a result of childhood sort of high levels of chronic stress. With depression, medication is one means of treatment. But actually, more often than not, and more effective than not, is cognitive behavioral therapy. Remember, it's a pill, not a skill, so medication can help, especially in very severe cases that do respond to medication. But CBT on its own has been shown to be as helpful, if not more helpful at times, than medication, and together with medication, sometimes helps sort of even more. And cognitive behavioral therapy is very problem focused. So, what is the issue at hand? What aren't you able to do that's leading to your problems in life? It's action oriented, so that's the behavioral part. I talked about behavioral activation. Individual make a behavioral activation hierarchy, things that are easier for them to do and they have more motivation to do, as opposed to things that are much harder. I had a very severely depressed patient once who the basic thing that we started with in terms of the behavioral activation was simply just getting up out of bed and putting on lipstick. It was something that she said made her, she said she used to enjoy putting on makeup and playing with makeup, but hadn't done it at all. In fact, she hadn't showered in months at this point. But we started very, very simply because it was very hard for her to even get out of bed. And we ended up actually doing therapy over online, over the internet, because she had such a hard time getting out. She had also a slew of medical problems and an addiction to painkillers, opiates. So very difficult and very interesting case. All right, so and then we try and address some of the thoughts and the maladaptive behaviors that individuals with depression show. Similarly, anxiety disorders can be treated using CBT. Anxiety disorders are some of the most common. I talked about phobias and social phobia. These are anxiety disorders, just conditions. There are about 6 classes of anxiety disorders, and 40% of people at some point in their lifetime will experience some level of anxiety that is disordered. Stressful experiences are one possible cause. Effects in the brain are increased activation in the cingulate cortex and parahippocampal gyrus. There's also sort of a greater response to negative stimuli or anxiety-provoking stimuli in the amygdala and prefrontal cortex. So, like, say, fearful faces or fearful images. And there's more excitatory neurotransmitters, so more glutamate activity in the brain that may increase anxiety. And so GABAergic drugs, or benzos, basically benzodiazepine, are helpful in sort of reducing anxiety. However, they're not as much the primary treatment, partly because they are addictive and severely, very, very addictive, in fact. So SSRIs, the serotonin, selective serotonin reuptake inhibitors, are being used more and more. CBT also, like I said, can be used. And exposure, as I mentioned in class, is a very important, so that habituation or that desensitization is very important when it comes to phobias of things in the environment, social experiences. Social anxiety is actually a little bit of a special case. It's one of the disorders that we study in our lab. It's a special case because it doesn't actually respond as well to this sort of habituation, desensitization bit. So people are studying to see whether it's maybe not an issue in terms of just fear, but that perhaps reward circuitry is also atypical. Maybe social things that are rewarding for most people are not rewarding in individuals with social anxiety. And finally, just make sure to consider whether being sort of misbehaving is bad or not. This sounds like a weird question, but think about it in this way. So we might be losing function in one area, but that, or have lost function in some area, but that could actually force our brains to release functions elsewhere that we weren't capable of before. So, or that it's a trade-off. So in the case of a famous mathematician, the individual, and I want to say the film, there's a film, and I will tell you what it's called. Cumberbatch. Yeah. So the film is called The Imitation Game, and it is based on Alan Turing, who develops Alan Turing. Let's see here. I could be wrong about this. I've been wrong before. I think I am wrong. Sorry, that was wrong. So John Forbes Nash, actually not the guy from The Imitation Game, is another mathematician who, and also, by the way, if you look at Turing's thing, he also had some issues behaviorally. But Nash is actually from Beautiful Mind, which is another movie that's been based on this individual. So he develops schizophrenia pretty early in his life while he's working at a university. He was a brilliant human being and came up with a Nash equilibrium and such, but he had schizophrenia and still has schizophrenia. It talks about how he deals with it, or did deal with it. So it's actually interesting if you guys are sort of want to know more to either watch the movie or read a biography on him. Fascinating life. He actually had a son. So this is where I'm talking about releasing new functions. He had a son that was also brilliant in mathematics, became a mathematician, also developed paranoid schizophrenia. So if we're thinking about schizophrenia as something that starts from very early in development, perhaps it is the fact that this dysfunction exists, that these individuals are so brilliant in something like math, so creative that they can create equations and ideas that others cannot. So is misbehavior always bad? The question is, first, I think that we have to answer is, what is normal and why is that considered normal? Is it normal because it's convenient? Is it normal because most people are that way? Or is it normal because we just don't want to accommodate individuals that might think and be a little bit different, and not just a little, maybe a lot bit different, but it's a balance, right? It's an interesting balance to think about. Some individuals with autism, especially high functioning autism, have come to talk about how perhaps it's others that are not normal. Why is it that they're considered abnormal? maybe they are just interacting in a different way, and that perhaps similar to a physical handicap that we sort of think very, how do I say, the world is structured for individuals who say no language or can walk, broadly speaking. A handicap is a handicap only because our world is structured in a way that caters to someone who has use of all limbs, or can speak in some language or another. And anyone who can't is automatically abnormal. So we have to put it in perspective, all right? And then also, there is a little bit of ethical concern because there's research being done on how to improve the function of the brain. So what are we really doing? Are we creating something that potentially could be misused in the future? What if somebody who is quote unquote normal brain functioning uses neurogenetics, genetics like stem cell therapy or brain simulation to make themselves even better at something? And so there's room for concern there. All right, so that's the end of chapter 16. I'm just going to finish up the tiny bit that was left of chapter 15, and then we can be done with the semester. All right, so talked about association cortex, and let's see. Okay. All right, so I think this is where we were. Oh, this is chapter 15 proper. I need short chapter 15. Dropbox. Okay. So attention is where we left off. And we talked about how attention is important because we need to be able to filter out areas of our surroundings that we do not need and to focus on areas that we do. We also talked about visual neglect. You saw that woman who could only draw half a daisy and was ignoring the other side. In this dog, similar, he only eats food from half the bowl. He has a visual neglect. Just basically, there's not an actual visual problem. It's the animal or person ignoring a side of the world, not at all attending as if it's not real to that side of the world. Almost too much selection, right? Then other cognitive functions include planning, which involve the frontal lobes. We've talked about the frontal lobes as sort of the executive branch of our brain. It figures out sort of it makes decisions, right? It's part of what helps you ignore things that you don't need, remember what you need to do, what you've already done. And so it's an organizational aspect in your brain. It plays an organizational role. In the Wisconsin card sorting task we talked about, so this is a neuropsychological test of executive function or frontal lobe planning type things, cognitive flexibility. So the individual is shown these 4 cards, and the tester, the examiner, doesn't tell them what the rule is. So they have to just learn to match this card that shows up with one of the ones here. And so through trial and error, they'll realize what the rule is. So if in the case of this, they match it first to this, then the rule would be shape. So to the yellow card, if they match the green card to yellow card, it would be a rule of shape because they're both plus signs. And then they'd say get that wrong, for example, and then they would probably match this card to these stars. Now, the trick here is that once they match into the stars, the rules change. And the examiner won't tell them the rule is changing. And so for the next card that comes up, perhaps the rule is shape, okay? But they won't know that the rule is changing. They will have to learn that, all right? And so for individuals who have perseverative errors, this just means that they perseverate or insist upon some reaction. So they might, even after the rule changes and they keep getting it wrong, they may still be stuck on maybe the rule is color, the rule is color, the rule is color, okay? So keep saying that. And then social function is also highly cognitive in nature. It's a huge area because it takes up a lot of regions of our brain, social behavior, and understanding it is very difficult. Currently, it's very interdisciplinary. So we have computer scientists that are interested in it because they're trying to work with robots and robotics and sort of engineers to develop human-like behaviors, which are oftentimes social. And then we also have clinical psychologists and clinical neuroscientists involved in sort of understanding how the brain processes social information, how to treat deficits in social behavior and such. So one of the big cognitive processes involved in social functioning is theory of mind. This is the ability to understand what someone else is thinking. It's sort of like mind reading, but in a way, it oftentimes involves ourselves. And the ability to understand how perhaps someone is the same and or different than us in how they're processing something. So a common test of theory of mind that they do with children to test the development of theory of mind is that they will show that child a picture, and in the picture there'll be, say, a girl, and the girl will go, will find a box of cookies on the table, and she will, well, let me start all over. Okay, so there are two people, they walk into a room, there's a box of cookies on the table, they both see that, and then one of them leaves. The other girl moves the box of cookies to a different cupboard, and they ask the child, and then she leaves. Then the girl who left initially walks back in, and they ask the child, where do you think she's going to look for the cookies? Somebody with theory of mind would know that that girl is going to look in the original cookie location because she wasn't there to see the cookies being moved. But somebody who has deficits in theory of mind would say, oh, she'll look in the cupboard where the cookies actually are. And that would be impossible for that person to know, right? Because they weren't there when things were being switched around. Okay? So that's theory of mind. Empathy, the ability to relate to others or sort of understand how others are feeling, has also been related to theory of mind and to activity in the dorsolateral prefrontal cortex. Humans and monkeys are actually unique in that we can identify ourselves in a mirror. Many other animals cannot. So even if a cat reacts to its reflection in a mirror, it does not understand that that is them. They actually try to play with that image as if it's not them. So recognizing our own faces versus the faces of others that are familiar leads to more activity in lateral prefrontal cortex and lateral parietal cortex. Right, so a monkey realizing that that's him in the mirror. And recognizing self can also help us understand ourselves, our emotions, why we behave the way we do, and help us in self-regulation. So prefrontal regions are actually really important. So we mentioned that they're active, these prefrontal regions active when we recognize ourselves, but they're also important for self-regulation. So children with ADHD that oftentimes have great high levels of hyperactivity have poor self-regulation. Individuals who don't have a lot of self-control, this is poor self-regulation. So someone who maybe binge eats. And it could be that this poor self-regulation is a result of either slower development of prefrontal cortices or less connections between prefrontal cortices and the lower level regions that have developed. All right, so I mentioned that we need an idea of ourselves in order to compare and create ideas of others and to interact socially. So if I had no idea how I would feel if somebody, say, if somebody broke up with me, for example, if I don't know that being broken up with makes one sad, makes me sad, then I would have trouble ever really knowing how a person's going to react or sort of feel in that same situation, right? So oftentimes if we're trying to understand a friend or understand why someone feels the way they do, or even decide how to behave in a situation, we oftentimes start with ourselves. What would I do? What would I want somebody else to do towards me in this situation? Okay, so it becomes really one integrated process, the self and the other. All right. And then last couple things, neuroeconomics is an area that my lab also studies. This is the ability to actually understand how decisions are made in the brain. So economics being, sort of like money related decisions. But this is, you can actually have social neuroeconomics. You can have monetary neuroeconomics, like how do we make sort of decisions based on our social interactions, how do we decide to or not to talk to someone or trust someone, but also sort of consumer neuroeconomics, how do we decide to buy this bag of chips versus this other bag of chips. So combines a number of different areas. And it's a new and upcoming field, also sometimes referred to as decision neuroscience, especially if it's not as economic focused, so if it's not more consumer focused, we call it decision neuroscience. Studies the brain activity of people as they make decisions. So we have two different kinds of decision systems. We have a reflective system. This is a goal-directed, sort of slow, rule-driven, and kind of not emotional process. And this is involved in, we sort of see activation of the ventromedial prefrontal cortex for this sort of reflective system. Then you have the reflexive system. This is a quick, automatic, very emotional decision. And that's more lateral prefrontal regions, medial temporal, and posterior parietal. If you look back, lateral prefrontal region is involved in perception of self. So it's sort of reacting based on your own feeling. All right, so medial temporal and posterior parietal cortex. And then finally, I just want to bring up intelligence, because intelligence we think of as a cognitive process also, the ability to think about something, know things, and this sort of morphed. So it started out as this G factor, which sounds kind of cool, general intelligence factor that Spearman came up with, but there's really no general intelligence center of the brain. And when we look at brains of individuals who are highly intelligent, such as Einstein, we actually see the brain size and weight is the same, roughly, average, but that perhaps connectivity is actually what gives us intelligence, the ability to synthesize information together, right? So, and more specifically, glia to neuron connection. So you sort of have more support staff to the amount of neurons you have, right? Glia being your support staff. And more specifically in the inferior parietal cortex. So that's just one region that this could happen in. And if it is inferior parietal cortex, well, then you'll see more sort of improved mathematical reasoning abilities. Okay, so this is Einstein's brain, guys. Woo! Looks just like every other brain. Okay. But if you guys remember in the beginning of the semester, I talked about this idea of multiple intelligences. That was not me. Multiple intelligences, and I had you guys rate what you were on, like sort of where you were most intelligent. Many of you were intrapersonal and interpersonally intelligent. That's a social intelligence that is not at all measured by any form of intelligence testing currently. Right? So keep in mind that what that means is that you're not being captured to the full extent that you are able, okay, when it comes to a intelligence test. All right, so words could be easier for some people, whereas others can express themselves best through music. And that does not mean that one is smarter than the other. It means that you guys have different abilities. The logical, mathematical person may not be so great in the linguistics. Okay? So it's all a matter of perspective. And then finally, we have two different types of thinking. Convergent thinking is someone that looks for one answer to a question, right? This is what most intelligence tests measure, okay? So, and the areas of the brain involved in this kind of thinking is temporal and parietal lobes. So if there are lesions in these areas, the individual won't do so well, okay? 2 + 2 doesn't equal 5. That's not the answer. You're wrong, okay? Whereas divergent thinking is a form of thinking that actually challenges the person to look for multiple solutions to a problem. So how many different ways can you use a pen as the example here, but it could also be how many different routes are there to this ultimate ending? How many different ways can this problem be solved? It requires more of an abstract and flexible thinking style, and lesions in the frontal lobe will impair individuals. But most intelligence tests don't actually look for divergent thinking. You can find ways that people think differently about similar topics, for example, but it doesn't challenge a person to come up with more than one way of thinking about something. Is intelligence heritable? Is it something that we get from our parents? Hebb would argue partially yes. So there is some intellectual potential that's innate, and this is highly heritable. Can't really measure this. But then there's this so that's intelligence A. But intelligence B is the kind of intelligence that you can measure, and this is more affected by learning and experience. Things that we experience throughout our environment and through development, and this is what intelligence tests measure. So we can't really test for, he says, the innate potential that someone has. So for example, say somebody is raised in a lower economic status sort of situation, high stress, not just low socioeconomic status, but also high stress, perhaps single parent who was unemployed or abusive childhood, that sort of thing. They might have actually been born with a high innate intellectual potential, but the thing that's measured for them, the observed intelligence, is really just it might actually be pretty low. They might have a very high intelligence A and very low intelligence B, purely because they didn't have the opportunity to learn as much as they could have. So potential versus learned, sort of finite. Okay, and then experience and learning. We've talked about increases in number of synapses and glial cells. And our support staff is important. Remember that. All right, so that is it. That's all I have for you guys. Thanks for sort of sitting through this. I know it's longer than 15 minutes. It's an hour. Good luck on your exam. I will email you guys shortly about details for that. Thanks, guys.